We're very pleased to have Dr. Pirich join us today, since this is hematology oncology, and she will be able to give her expertise to some of the questions, how they're interpreted, et cetera, not to mention the content itself. So just remember, we look at the board review of not only the right answer or the best answer, because sometimes a construct of a question may not be perfect, but yet there are pieces of the construct of that question that should be able to push you to the right answer, as long as you're appreciating that. Now, Dr. Carney is still on with us. He's on vacation, so we appreciate him joining us still. So he's going to handle the chat for me, because I'm all by myself here in front of this computer, and you know that could lead to disaster. But hopefully we'll walk through this appropriately. So let's get started. Again, everyone put their system on mute unless you have a question, but Dr. Carney may handle the chat accordingly so that we won't be talking over one another. And then if we finish a little bit earlier, it can be more open to questions for the good of the group. All right, so let's go through number one. And the questions are up on the screen, and the right answers obviously before you. But the trick for this is a 3-year-old girl with some fever, petechiae, ecchymoses, and you're really getting down to looking at, is this leukemia or is this aplastic anemia? And so if you can't read the first part to understand that's the essence, they don't say of the following which is most consistent with diagnosis of aplastic anemia as opposed to leukemia. So you have to read the first part of the sentence, first part of the question, and go, okay, that sounds like leukemia, but now the question is really, what is the nuanced difference between leukemia and aplastic anemia? And the way I look at it, you know, leukemia is more of a systemic disease, if you will, and that may not be the exact right word, whereas the aplastic anemia is specific to the bone marrow not producing. And so if you just think through cervical adenopathy, lymphadenopathy, hepatomegaly, localized bone pain, those are systemic symptoms and systemic signs that go with leukemia. The normal spleen size would be more aplastic anemia. Put another way, with leukemia, you would expect a big spleen size. So the answer in terms of most consistent with aplastic anemia will be a normal spleen size, okay? Number 2 is a 5-year-old with epistaxis. The real trick here is for you to understand in this question, what does a PT represent? What does a PTT represent? What's a normal platelet count? Because you kind of always look at those 3 in concert with one another. That's generally how the questions are going to be going, because they're really trying to be sure you understand the difference between those 3, or sometimes maybe they're not mutually exclusive to get the answer. So when you look at this question, also this is a classic of girl as opposed to boy. And again, look at the age, look at the gender, look at the time of year if it's there, because sometimes that will help you at least eliminate some answers. So if you look at factor 9 deficiency, classically, you know, since she's a female, that wouldn't be the answer. You have to look at this and say, well, my platelet number is okay. That doesn't mean I don't have a platelet problem. But within the stem of a question, if it's a platelet problem, you're expecting petechiae. You're just, that word would push you toward it. Well, let me at least think about platelets here. Not that that's the be all and end all, but the fact of a good test taker says, well, that's not there. And hence the platelet problems, which would be, you know, part and parcel to what's going on here, would not be the right answer. And then if it's a platelet problem, then you have to say, well, how do I fit the elevated PTT in with the platelet problem if that is going to be the right answer? And so if you look at Glanzmann's, that's a platelet problem. And okay, well, maybe it's a qualitative platelet problem, not a quantitative, because you should know 240,000 is normal, but it still could be a qualitative. In other words, the platelets don't work right. But if it's going to be Glanzmann, then you've got to look at the PTT and make that be part of it. That doesn't go with Glanzmann, hence it's not that answer. The lupus anticoagulant, again, will be more of an increased PT, not PTT. The vitamin K is going to be a PT, not PTT. And of course, the PT is normal. So if nothing else, by default, it's going to be von Willebrand's disease, which, as you know, is a qualitative platelet problem. It's a little more sophisticated than that. But along with that and that elevated PTT, hence the right answer is von Willebrand's. Okay. Next is, yeah, go ahead.
Other thing that I would add, Jimmy, is that with lupus anticoagulant, you have the abnormal values of prolonged PT and PTT, but you usually don't have any evidence of bleeding. So right off the bat, this kid has bruising and nosebleeds, so that's going to eliminate the lupus anticoagulant. They usually don't have bleeding symptoms.
Good point. Good point. Okay, number 3 is, and you have to look at the STEM, the most appropriate next step. And so even if you look at this 13-year-old, hemoglobin of 8, low MCV, but a red cell distribution that's increased, normal white count, if you will, normal platelet count. Oh, wait a minute, that platelet count's actually high. Well, you got to put that together, and I know the picture maybe doesn't come across as well as I'd want, but those are certainly cells that don't have much color. If somebody is not muting their, and we're hearing a lot of background noise, so please put it on mute. Okay, thank you. So the appropriate next step is to assess that, well, here is a child that, if you didn't know, many times with iron deficiency anemia, you have a high platelet count. Now, if you look at the literature, you actually can have a low one sometimes, but the classic answer, run-of-the-mill, is an increased platelet count with iron deficiency anemia. The age is right. They don't give you the diet. That would have been nice. But the logic is to look at this as iron deficiency anemia, and therefore you're going to treat the patient with iron and see how they respond. Now, a good test taker would look at measuring a serum ferritin and measuring a serum in TIBC. Those essentially would accomplish the same thing, hence neither of those answers are right. And if you can't pick up that based on the numbers above, that this is a iron deficiency, not a thalassemia, then you're caught in that hemoglobin electrophoresis answer. But looking at the red cell distribution width helps you differentiate between those two. And then you would not perform a bone marrow when you've got good white cells and good platelets and just an anemia problem, at least as the next step. And so the answer is going to be response to oral iron therapy.
Dr.
And number 4, I'm sorry.
Dr. Could you,
yes,
or you or Dr. Pirich, just comment on the MCV, because that's what threw me off a little bit in thinking more of like a thalassemia and wanting to go down.
Well, and I'll let Dr. Pirich say, but this is going to come up in a question in the future here. Remember that the MCV drops before the hemoglobin drops in iron deficiency anemia. So if you're looking at that, by the time you get from a 70 plus all the way down to 56, you're expecting that hemoglobin to have dropped. Does that make sense? In other words, you have to be careful that you realize what I just said, because a kind of a normal hemoglobin, but yet a little low MCV would still push the button for you to have to consider iron deficiency. Do you see that point? Laurie, Dr. Pirich, you want to comment?
Were you just thinking, Liz, that you would have expected the hemoglobin to be lower with that degree of low MCV?
More so that I would, if it was an iron deficiency, I would have expected the MCV to be a little higher, I guess, was my.
No, I would have, they should make the question better. They should have made that hemoglobin more like a 6 with that MCV of 56. That MCV is pretty low. The other thing, and it comes up in another question, that I think when they're going to try and make you go the thalassemia route, they're probably going to give you a red blood cell count when they give you stuff with thalassemia, because your red blood cell count is going to be normal or high in thalassemia, and it's going to be low in anything that has to do with a problem with production, like iron deficiency.
And remember, even though this picture doesn't come across, Liz, you've got the picture. You've got to somehow be able to look at the smear, and that smear is not 2 different red cells and, a thalassemic smear. So you've got the pictorial there. And so part of the testing that y'all are going to take are going to include pictures. It's not just the words. You've got to be able to look and see things like peripheral smears and interpret them. So that's the other part of this that makes it be iron deficiency anemia.
And real quick, Dr. Stallworth, is the red blood cell distribution, is it elevated in both iron deficiency and thalassemia?
Well, I'll let Dr. Pitch comment, but the red cell distribution width, remember, is not 100% either thing. But in general, I kind of think about it this way. You've got kind of two, in thalassemia, you have two different sets of red cells, if you will. And so they kind of cancel each other out. And so you kind of have a normal red cell distribution width, whereas in iron deficiency, it's all one thing. And so you have an increased red cell distribution width. Now, that's just the way I kind of look at it in my brain. It's more sophisticated than that, so I'll let Dr. Pearich come in.
No, I think that's a good way to look at it.
Okay, all right.
I think that's fine.
All right, so let's go to number 4. A lot of you missed number 4. Previously healthy. Now there's a big one, previously healthy. So you kind of think, well, previously healthy, you've had hereditary spherocytosis all your life. You've had pyruvate kinase all your life. You've had sickle cell beta thal all your life. You've had G6PD all your life. Now, an autoimmune hemolytic anemia can certainly be a disease that comes later on. Now, that does not mean necessarily, of course, that a presentation of hereditary spherocytosis couldn't be later on. But the point is, when they say previously well, that should register in your mind. You should think, okay, this is probably not some chronic problem. I'm not trying to put all the eggs in the basket by saying that. I'm just trying to say, let's take that and let's see how the question falls out and look at the answers, and then maybe use previously healthy to help us a little bit. Again, not the be all and end all for all these answers, but just another little nuance that might help you if you could get it down to 2 and you said, well, gosh, sickle beta thal, she should have had problems before, so I'm going to go the other way. Just as an example. All right, she's got icterus, dark urine pallor. Now, you know, with this hemoglobin this down, white cells are okay, platelets are okay, retic up. You know there's a hemolytic process going on with that retic count. And especially with the bilirubin. And of course, the smear has polychromasia. What does polychromasia mean? If you don't know the word, it doesn't help you. But you know, polychromasia are red cells that are young and rich in hemoglobin, so they're like retics. If you see a lot of polychromasia, you see a lot of young red cells being put out, if you will. Now, that does say a small number of spherocytes. Now, there's another question coming up here, and you're going to have to be alert to peripheral smears, that just because you were to see a spherocyte doesn't mean, oh, it's hereditary spherocytosis. I mean, there are lots of things where you can see spherocytes along the way. I'm not saying it's not hereditary spherocytosis, but you can't fall into an answer because I've got the spherocyte on a smear that makes it be hereditary spherocytosis. You've got to read the rest of the question, okay? And so this is a kid that when you look at it, well, number 1, use the gender. It's a girl, G6PD. I know it has been reported in a female, but I would use the male to say, since this is a female, it's not G6PD. What's missing in the stem of this question if you thought it was HS? Well, you got the spherocyte there, so that goes forward. But where's the splenomegaly? I mean, it's just not there. And sure, they might have chosen not to give it to you, but you at least should beg the question, well, if this is that, why are they not telling me a spleen or giving me a family history? Just something that is missing for that to be the right answer. The sickle beta thal, I said previously healthy. Pyruvate kinase is much rare, but that's, again, something that you, if you will, have had all your life. It's an enzyme deficiency that it's part of red cell metabolism. So just getting it down, the trick is that within the stem of the question, they talk about that upper respiratory infection. So you get it, and then here comes the hemolytic anemia, and that's an autoimmune hemolytic anemia. The other part of the question that could have been in here to help you would have been the DAT, because what would you expected the DAT to be? Dr. Pirich, can you help them with that, please?
It is. The DAT would be positive and autoimmune hemolytic anemia.
Right. So once again, if that had said negative in there, you would have had to use that to move away from this being the right answer. Okay? So just remember, your autoimmune hemolytic anemias are DAT positive. Your ABORH, DAT positive, right? HS, not DAT positive. It's a membrane defect. It's not developing an antibody. So the DAT is very important for you to understand what that is, because that is so many times part of a question, okay?
And they might even give you this stem and then ask what would be the next best test. And the DAT would probably be the test that they would want you to do on a stem of a question like this.
Exactly. Remember, the first stratifier with a hemolytic anemia, is it DAT positive or DAT negative? I mean, it's just your first major stratifier. Okay, next, number 5, this is just knowing the side effect of vincristin. And one of the side effects of vincristin is SIADH. So that's answer D, and that's just a database. Now, if you can't understand the numbers that force you into SIADH, then that's another thing you've got to think about, because the hyponatremia is SIADH, right? If you were to look at increased sodium renal loss, well, then, you know, that sodium in the urine would be 150 or something like that. So you kind of have to be able to be sure you interpret, being able to interpret. But the bottom line is just, you kind of just know vincristin, you know, SIADH is what you always are alert, know, move on. I mean, there's no trick here. Okay. All right. Next. Number 6, a lot of you missed. And as you go through this, they tell you this is a patient with CF. So CF is a pancreatic insufficiency. You have problems with fat and protein malabsorption. Okay, so we know that as our database. Since we're in a HEMOC talk, here's the results: the hemoglobin of 9, which is low, and the albumin actually is pretty good, but the retic count is 12%. Now, when you see a low hemoglobin and a high retic, you kind of think about hemolysis. Now, you could catch me. For example, if you had an iron deficient patient and then you started them on iron, they may still be anemic, but the retic would be up. That's what you do. You always follow up a patient with iron deficiency anemia by getting a retic maybe in 7 days, because they should be reticking. And if they're not, you might not have the right diagnosis, or of course they're not getting the iron. But just to play the game, you see a retic like that and you go, well, this is more likely a hemolytic anemia. Well, that's borne out with the polychromasia, but you do have some schistocytes. Now, schistocytes mean that the red cell membrane ain't right. There are lots of reasons for that, but it's not your nice biconcave red cell. So there's something that's impacting on this hemolytic anemia that's not allowing the red cell membrane to be in its natural kind of biconcave, what am I trying to say, how it looks. And so you look at these and a bunch of schistocytes. So you're going to have to play the game of, this is a hemolytic anemia with and has a lot of red cells that are not formed correctly on the smear. Now, you could look at this by saying, well, wonder if he had had a heart valve that maybe had just been placed, and maybe these are red cells going through a heart valve and being sheared off, and they may give you schistocytes, for example. But on this patient, they're telling you, you have to connect the dots of why would a patient with CF be anemic. And so then you look at fat-soluble vitamins, where they may be malabsorbing, ADEK. Certainly, he could be anemic if he had a bleeding problem, but they don't talk about a bleeding problem. And so you're kind of left over with, well, what else? Vitamin E, deficiency gives you a hemolytic anemia and a thrombocytosis. That's classic vitamin E deficiency. Hemolytic anemia, thrombocytosis, there's the platelet count of 350,000. Hello, alpha tocopherol is vitamin E. I mean, that's the answer. And so all of the others, really, C, B12, folate, B, thiamine B, those are all not fat-soluble vitamins. So they're really asking you to connect the dots to understand what are the fat-soluble vitamins and which deficiency would give you a hemolytic anemia, and it's E. So the answer is A. Okay? All right, moving to the next one. Number 7, I think, 14-year-old, best treatment. Well, this is a girl who's got a low hemoglobin. She is not reticking. Her hematocrit is low. And when you look up there, they talk about her menarche and all that somebody is on. Somebody needs to put on their mute. Mason, put on your mute, please. Thank you. So, and then they tell you, the abdominal exam is normal. I mean, they're trying to help you that she doesn't have anything bad going on, and she's actually having this bleeding in between periods. So she's a dysfunctional uterine bleeder, and so just looking at she's iron deficiency. So the best treatment is to restore her iron, and a daily vitamin won't do it, and an iron food won't do it. Yeah, that's going to be part and parcel eventually, but the best treatment for her is to go ahead and, is to really figure out what's going on with her dysfunctional uterine bleeding. But of the answers below is to give her oral sulfate, iron sulfate. Number 8, here's one, Jeremiah, back to you. Now here's this red blood cell count Dr. Pirich was talking about a while ago. And so lo and behold, what is the answer? Hemoglobin electrophoresis, because of the point she made earlier about it being in the arena of your thalassemias. So that's really the take-home point. Dr. Pirich, you want to comment on this question anymore?
No, I think that's, and also your ferritin value in this question is normal. So repeat the course of iron in someone who has a normal ferritin, it's not, they're not iron deficient.
Correct. Now, and to bring the point home, notice that this retic is low. So this is not a hemolytic anemia, hence the direct Coombs is not the right answer. Had the retic been high, depending on the rest of the question, then that might have been the right answer because that's the big stratifier. But since the retic is low, you're not in a hemolytic process. That's why you don't order a DAT. Okay? All right. Number 9. This is a great question. I mean, in the sense of the whole point of the question is for you to know what the diagnosis is. I mean, that's really the point of the question, because if you can't get the diagnosis, then your answers are going to fall flat quickly. So the real trick here is reading this question. What is the answer? Well, number 1, you got a good white count, you got a good platelet count. You look at the age of the patient, had a viral illness, he doesn't have anything else going on. He's well appearing. Use the word well appearing to don't, no lymphadenopathy. In other words, no liver, no spleen. They're trying to get you away from some wild something going on here. The LDH and the red cell adenosine deaminase are normal, meaning this is probably not, it could be hemolytic there, or it could be cancerish, however you want to look at it. They're trying to help you. That's not what's going on. And so even though it sounds like, well, this kid doesn't sound too bad, so I don't know what it is, but I'm just going to watch him, well, you'd get the right answer. Good for you. But the real trick is to know what the diagnosis is. And so what is this diagnosis? This is TEC, transient erythroblastopenea of childhood. Follows the viral illness, right age, leave it alone, watch it, and it'll come back. Now, you do have to watch it. I mean, it can go on down and he can go into heart failure, and then that's different. But at a hemoglobin of 6.8 and a 22-month-old, you're going to sit there. You're not going to take the chance of a blood transfusion on him with the benefit versus risk unless you have to. So this is TEC, answers close observation. I saw something pop up from Dr. Carney. Remember, a multivitamin with iron does not have the amount of iron per day that you need to replace iron stores. So on that previous question, if that's what you were asking, Scotty, I couldn't, you know, you have to replace iron. So you have to do supplemental iron like 3 times a day, not a daily vitamin. That doesn't give you enough iron to replace stores. They maintain, but not replace.
That's
Okay.
exactly what they were talking about, Stoller. Thank you.
Yeah. Number 10 is the tricky question. And one person got this. So therefore, this is a tough question. And I'm the first to admit that the better way to have phrased this question would have been to look at which, and Liz, this comes back to what I said a while ago, is to look at which child is approaching iron deficiency anemia, or has the beginning of iron deficiency anemia. Because the real essence of this question is to connect the MCV with the hemoglobin in the 16-year-olds. And the real trick for this menstruating female, because she's Tanner 5, they don't tell you she's not, so would be a 12-2 would be fine with that MCV. If you look at the boy at 13, which sounds pretty darn good, I mean, would be normal, but his MCV is 80. Well, you know, 70 plus the age in years. He's 16, it should be 85. So what they're trying to get you to answer, to see, is therefore he's approaching iron deficiency anemia. His MCV is starting to drop. I told you a while ago, the MCV drops before the hemoglobin drops. So that's what they're trying to pick up on. I do think that this is tough. And if you answered E, that certainly, I understand why you answered that. But I'm just trying to show you that had the question been something more akin to the MCV being 70, I think that would have been better. Or the answers being the boy is approaching iron deficiency and the girl isn't, or however you want to say it. I hope you get the teaching point of this question, so don't get all hot and bothered by it, because I don't think it's phrased in the best way that it could be.
Was this a Metzler's number or Metzler's?
Metzler's index?
Yeah, no, okay.
I mean, I could do it. I didn't do it. I'd have to do the math. I mean, Dr. Pirich, have you done the math on that for the Metzler's
You
index?
do the math, but if you look at the choices, like none of your choices have anything to do with thalassemia trait. And that's what you're really, when you're calculating the Metzler's index, you're trying to determine whether something's more consistent with iron deficiency or a thal trait. And none of your choices are asking for that. So I don't think you would need to take the time to try and calculate it.
All right. Number 11, the bleeding time is a screening for what? And the bleeding time, remember, is platelet function. If you have a low platelet count, there's no point in doing a bleeding time, because the low platelet count it has thwarted your ability to interpret a bleeding time. So you have to have a normal platelet count, and then a bleeding time helps you with the function of those platelets. So that's why you do a bleeding time, okay? And all those others are in the coagulation profile, et cetera, et cetera. And yeah, you can have problems with vascular stability in a petechial rash. I got that. But again, that's looking at figuring out what the diagnosis is. And if that vascular instability is associated with a low platelet count, then the platelet function test goes out the window. The bleeding time goes out the window anyhow, because it's going to be prolonged because you don't have the number of platelets. But in general, bleeding time is platelet function. Okay. Number 12. Once again, look at this: sickle cell disease, the retic 0.8 with this low hemoglobin, and hopefully most of you recognize this as an aplastic crisis, right? I mean, he's in trouble. He's a PICU patient, but this is, the white count's really okay. They don't talk about fever. He'd have to be jaundiced for hyperhemolytic. They'd have to talk about a big spleen, liver and/or spleen with sequestration. Yeah, he could have a vaso-occlusive crisis going on too, but the numbers dictate that he's having an aplastic crisis. 13, The
The
trick
only other
here
thing
is
on that one, on 12, just to remember, if they're going to give you splenic sequestration, in addition to maybe if they don't give you the spleen, if they give you they're going to give you a lower platelet count, because you're going to be looking at the hemoglobin and the platelets being trapped in the spleen for splenic sequestration. So that platelet count being relatively normal is going to help you with this question too.
good point. And the next question, 13, you've got a mean corpuscular hemoglobin concentration that's elevated. If you just saw that, that classically goes with the right answer. But even if you didn't, then you've got why are they telling you about the cholecystectomies early on in males? Well, logically, that's a chronic hemolytic anemia that's setting you up for gallstones. And then when you look at the white count, that's fine. The platelet, the retic that's elevated. Now here's again a hemolytic anemia, okay? And the giveaway here is the MCHC. And so that classic answer is hereditary spherocytosis, right? And again, it's a girl. G6PD comes off. Diamond black fan, you don't have retics. Elliptocytosis, okay, but then it's that MCHC that pushes you for those spherocytes. And then we're back to the pyruvate kinase. Dr. Pirich, you want to comment on pyruvate kinase in terms of what would be a classic question if that's the answer? I mean, that's so rare. I just don't think that's it.
I don't see them asking that because it's so rare. I think they're way more likely to ask something about G6PD if they were going with an enzyme problem. I don't have much more to say than that.
Okay. All right, 14. 6-year-old with leg pain. Now, you know how bad leg pain in kids is. It's like back pain. You just can't ignore it. So she's got leg pain that pushes you. Now she's petechia purpura, spleen. That's systemic. That's generalized. Of course, she's anemic. She's got a low white count, low platelet count. So now you're putting together a systemic disease, if you will, or a generalized disease, if you will, with the bone marrow not working very well. And so that pushes you away. Remember our first question where you had the aplastic anemia, you didn't have the systemics. Here you've got the systemics. So you put that together and that's going to be leukemia, right? Right. And then if you had an autoimmune hemolytic anemia, well, let's see, where is our jaundice or where's our retic count? Because an autoimmune hemolytic anemia, remember, can have a thrombocytopenia with it. That's that Evans syndrome that you can get into. But where's the preceding viral illness? And then ITP, you don't have splenomegaly classically with ITP. Is that a fair statement, Dr. Pirich?
Yeah, and you're not going to have that hemoglobin of 6.3 with ITP unless you've had a lot of bleeding, and they don't describe this girl as having a lot of bleeding.
Exactly. Okay, number 15. Now, a lot of y'all missed 15. So this is something y'all, in fact, it's really interesting. I'd asked Stephanie to go over, because I'd seen this over the year, where y'all's knowledge and ability to treat hemophilia, and you've got to know it. Dr. Pirich, you want to comment on you just have to understand with hemophilia, you have to overreact to what may seem like a minor trauma in a hemophiliac, but that's what you do. But, and I know he's had no loss of consciousness, but he fell. He was not wearing a helmet. He's got a small hematoma. They're trying to tell you, oh, it's no big deal, but he's a hemophiliac. Any little thing in that you would consider in a normal child, that little thing in a hemophiliac, you're in there giving them replacement therapy. But Dr. Pirich, you want to comment?
Yeah, I mean, the same thing, and we talk about this if a patient comes to the ER. You know how long it can sometimes take to get a CT, so even that's not going to be, you want to treat first. You don't want a kid waiting for 2 hours and bleeding in his head and then get the CT and say, oh yeah, I should have given him factor. So this is one of those situations where you treat first and then ask the question later. And they're telling you, he fell from a height because he fell off his bicycle and he didn't have a helmet. So 2 red flags of a head injury in a hemophilia patient. this was a healthy kid, you would do probably B, discharge line. But this isn't a healthy kid, so.
All right. Okay, and we used to, and Laura, this is a digression here. They used to look at us if it's factor 8, factor 9, is it 1 unit per kg or 2 unit per kg to increase it 50%, to increase it 100%. We'd have to know based on what the injury was. Do you want to increase 100%, 50%? Do they even get into that anymore, or is that just not?
Well, you have to look at what the risk is. So if you're worried about an intracranial hemorrhage, then you want to correct them to 100%. You also have to know whether they have factor 8 or factor 9 to be able to do the calculation to do that. Most of our families know what their dose would be for major injury versus minor, and most of them hopefully are going to bring that factor with them when they come to the ER too. So it'll help with the time constraints.
Okay. All right. Number 16, I think most of y'all got this. I mean, vegan macrocytic anemia. I mean, my God, what more do you want? So the answer there is with a hypersegmented polys, vitamin B12 deficiency. Now remember, the answer might be cobalamin. You have to know B12 is cobalamin, right? Okay, it's not here, but I was amazed they didn't put it because I remember seeing that before, and I was just looking quick for B12 and I didn't see it. And so just remember that, but this is kind of a classic. Number 17, I think most of y'all got this right. This is the onion skinning, this age, and generally you get down to osteogenic sarcoma and Ewing's, and you just have to know the onion skinning and what it goes with. Now, just parenthetically, osteomyelitis, where's the fever? He's afebrile. So if you answered osteomyelitis, because you can have some elevation of bone, with osteomyelitis, but no fever, it's not osteo, okay? All right.
Jeremiah, did you have a question?
Yeah, if there wasn't onion skinning, I think that gave it away pretty easily. If there wasn't onion skinning, I can't really read that radiograph all that well, personally. So I wasn't sure, without that big clue, what might be leading for us with Ewing sarcoma.
I would say the osteolytic lesion, and then also soft tissue mass. I think that this isn't the greatest question to me because I think the radiographic findings between Ewing's and osteogenic sarcoma overlap a ton. And I even had to kind of look it up because you can have lytic lesions in osteosarcoma too, but the classic would be lytic. What classic for osteosarcoma is sclerotic with the sunburst pattern. Classic for Ewing's is lytic with this onion skinning, but there's a ton of overlap. So I don't think this is the best written question.
I wasn't sure if the placement as well, like the distal femur, I thought that might be also Ewing.
Well, osteogenic sarcoma could easily be there. I totally agree. Whereas you could move to the flat bones for Ewing. I do agree with that comment. But this is a pattern recognized question. The pattern recognizer is onion skinning. Yeah. I mean, you can play with it all you want, but the pattern recognizer is onion skinning. Yes, and that pushes you to the right answer. Okay. All right. 18, 9-year-old, ALL, been in remission. And this is a classic of the answer being the testes. And why is that? Because you can palpate it. Yes, you can palpate the liver, but you can't get your hands around the liver. And so you know, and that certainly leukemia can relapse in Hodgkin's disease, can relapse into the testes. But this goes way back in my years, always taught that when a male patient comes in who's had cancer and maybe in remission, you always go in and not skip the GU exam, because it's an easy place that you can pick up by a physical exam where a relapse may be coming. And it's just easy to do, and it's right there for you to fill. So the answer is testes. Dr. Pierce, you want to comment?
I think that they're just trying to, it's a boy, and so the most likely place for him to relapse is actually in his marrow, but they, they don't have anything like that for a choice. So they're just trying to make you remember that boys can relapse in the testicles with ALL, I think is what they're saying with this one.
It's an easy place to examine for that and interpret. Okay. All right. Number 19. Now, this is a great question. And there's a database here that I'll try to be sure you have. And this did have a picture, but we couldn't get a picture to translate, so I apologize. But here's a 2-year-old with rudimentary thumbs. Now, that adjective rudimentary is very important as opposed to absent thumbs. So rudimentary means they're there, but they're rudimentary. He's also short, obviously, a little failure to thrive. He's got some hyperpigmentation. And what is the disorder? Well, this is where you put together those particular skin findings, rudimentary thumb, short stature. I mean, that just puts it into the Fanconi anemia. Now, here's key, because I always would look at that, and I remember in my younger days, which was many years ago, I would know it had something to do with the thumb. But this is where you got to get it down, because I'd start missing up on thumbs and absent thumbs versus rudimentary thumbs, and absent thumbs are going to come up here in just a minute. Think about the syndromes of the ray like that, of the thumb ray. And so the things that always go to me is the fact that you've got the rudimentary thumbs, Fanconis, the no thumbs, which we'll come to, the wrist arm abnormalities, Holt-Oram, and then radius TAR syndrome. And you just have to get that in your brain. So if they go for the wrist, it's Holt-Oram. If they go for the thumb, depending on the adjective, it's Fanconis or Diamond Black Fan. If it goes for the radius, it's TAR. And so with rudimentary thumbs, it's going to be Fanconis. Now, I think Colin Laura put in, he wanted to know in a female, what's the right answer if the question had been in a female, what you examine, if that Hodgkin's question had been a female.
Yeah, and I think it was a leukemia. I think that he was a leukemia patient. So, yeah, I don't know that I can't make it fit a girl.
Okay. There you go, Colin.
Sorry.
Now, the wrist and the arm is Holt-Oram, HoltOram. And they love that syndrome. And many times they'll ask you what the heart defect is with that, and it's an ASD. So your Holt-Oram is your arm, but it's going to concentrate on wrist, but it can have some forearm abnormalities and fingers, don't misunderstand me, but the wrist pushes you to Holt-Oram. The thumb, Diamond Black Fan or Fanconis, whether it's rudimentary or absent. The radius, TAR syndrome. And if you can get that in your mind, you've got it. Now, Bloom syndrome, and if you don't know what Bloom syndrome is, and the trick on Bloom, where they're getting you, is the hyperpigmentation. Because Bloom syndrome is a DNA repair problem, and they do have hyperpigmentation, and obviously they cannot fail to thrive. I'm not sure Bloom's has anything to do with the thumb. But they're trying to get you there on that. And then ALL, ALL is not, that's just anybody can get leukemia. This is not set up for this presentation. So please, and your TAR syndrome, they don't talk about the radius. They're talking about the thumb. Okay? You see the point, and I'm not saying you can't maybe in real life have a little abnormality, but the stem of the question would have to tell you that, or the picture. And I told you the picture didn't come across here, and I apologize, but you should be able to get this answer based on the stem of the question. Okay, let me look at my time. We got 10 more to go. Okay, number 20. A lot of you missed 20. The key is a 2-month-old, firm mass, 2-month-old, maybe thinking about hepatoblastoma, but it's pushing the kidney down. You kind of think of adrenal doing that. And the real trick is calcifications. And you see a calcified mass as opposed to a non-calcified mass, that kind of moves you from Wilms to neuroblastoma. Wilms being not calcified, classic neuroblastoma is. Now, we will see here in just a minute, another thing that might help you. It's just not in STEM of the question. I think that you probably should have, just by age, kind of worked a little bit with the hepatoblastoma and the neuro, because the Wilms tumor, not that you can't have congenital Wilms tumor, but it's classically, you know, your 4-year-old, your 6-year-old. So I think that if you had trouble with this question, it probably was between B and C, and it's the pushing the right kidney downward. Kind of says it's the adrenal, hence the neuroblastoma. Okay? 21.
Rhabdomyosarcoma in the adrenal gland.
A what?
Rhabdomyosarcoma in the adrenal gland.
A rhabdomyo, that's a muscle tumor.
Yeah, no, that wouldn't be.
Myo is muscle, rhabdomyo.
Using with that rhabdomyelo, like that too. I think adults get it more often, where it has all 3 different like tissue types.
Well, Jeremiah, welcome to pediatrics.
Or I just took step 3 this weekend. Sorry.
Okay, well, good for you, and I hope you got that right if it was an adult question, but we're not answering that question for an adult. No, adrenal carcinoma, that won't ever be the pediatric answer. You got to be, your pediatric tumors are your hepatoblastoma, your neuroblastoma, your Wilms tumor. I mean, those are your classic ones you get into, and that's what they want you to know. Yes, is there going to be a weird PNET tumor occasionally that Dr. Pierce can? Sure, but that's not what they're going. You know, they're wanting you as a general peds to know the classic tumors. Okay. All right. 21. Here's a kid who's chemo and's been exposed. His immunization is up to date. What do you do? Well, you know, you're going to give him the immunoglobulin to help him. And notice they say to prevent measles, not to treat measles, to prevent, because you know in the third world, patients die with measles who are vitamin A deficient. And so you treat them with vitamin A in the third world, because if you're vitamin A deficient and you get measles, it's a bad combination. Okay, but that's treatment. That's not the question. The question is prevention. And so you prevent it by using the IM immunoglobulin. Why not give the vaccine like you do if a baby is born with a hepatitis B mother, where you give the immunoglobulin in one leg and the vaccine in the other leg? Don't give them together because they counteract each other. Well, why not do that here? Meaning MMR vaccine plus immunoglobulin. Well, number one, his shots are up to date. Does a 3-year-old get an MMR? Number one. But if he were exposed to catch, oh, maybe we should. But it's a live virus. And remember, you wouldn't give a live virus to this patient, okay? So the answer is going to be just give him the IM immunoglobulin, okay? All right, next is the question 22. Everybody got right. You know, that's the Italian fava beans. My word, what more do you want? Male, I mean, that's G6PD. The blister cell might be on there. Notice this is reticus up. Again, it's a reticking. It's a hemolytic anemia. And the bilirubin's up. So if you couldn't get into the hemolytic process, you know, all those other kind of words that are in that question, you know, just put you toward G6PD. 23, I think everybody got, you know, it's a sickler, and you know strep pneumonia because of the splenectomy and the encapsulated organisms. 24, you know, if the woman whose father is a hemophiliac, then she's got his X chromosome, so she's going to be the carrier. And so if you just do your basic little chart, you know, she has a 50% chance of each of her sons to be affected, because she will give one of her X chromosomes to her son, and it's a 50% deal. So the answer there is 50% of the risk for her son to be affected. Now, when they ask questions like this, don't fall into the trap of, well, it's a spontaneous mutation, or wait a minute, are they considering lionization of the X chromosome? Don't go there. You know, play it straight up that this is just a classic genetic question, and don't get into all those particular weird iffies, if that makes sense, okay? All right. Next, 25.
Scott had a question about the role of vitamin A in measles treatment and prevention.
It doesn't prevent it, it helps treat it. That is, if you are vitamin A deficient and you get measles, it's a bad case of it. And, you know, just look that up. I mean, I don't know the actual pathophysiology behind that personally. Dr. Pirich may know, but it's not that you treat measles with vitamin A. It's patients who are vitamin A deficient who then get measles are going to have a more morbid and mortal course with it. That's why in the third world, measles can be a death and disease because of the malnutrition, ergo the vitamin A deficiency, and that's just a database question. And so we can look it up. I'm sure there's an answer to that at a pathophysiology level. I just don't know it. Okay, 25. Now here's this one that I was referring to a while ago. You've got number 1, a 6-week-old. It's a positive direct Coombs. Now, if it's a positive direct Coombs, and a lot of y'all missed it. So if it's a positive direct Coombs, you got to get down here. So ABO is positive direct Coombs. G6PD is an enzyme deficiency. That's not a direct Coombs. Hereditary schistososis is a membrane defect. That's not a direct Coombs. Physiologic anemia, well, that's not a direct Coombs. So you're down to A or E right off the bat. Now, ABO this is a 6-week-old. You know that RH has trouble right off the bat, and they go down fast. If you just look at the O positive, the A, I mean, this is a classic ABO incompatibility. There can be microspherocytes, and that's where if you saw that word and you wanted to answer HS, okay, but how did you deal with the positive direct Coombs? Because HS is Coombs negative. What you have to remember about ABO incompatibility, you always follow up an ABO incompatibility because that immunoglobulin, that antibody lasts a while. Those kids can hemolyze right on down. It can be a slow process on down because remember that they don't kick in for their bone marrow till 6 weeks or 2 months, hence physiologic anemia. Well, this is going to be exaggerated because of that hemolysis. So you always follow up an ABO incompatibility with a hemoglobin. It may be a big bunch of nothing, maybe very stable, maybe very, not a big to do, but you don't know that. And it's very, very subtle. RH is a big to do right off the bat. I mean, you're just, you're hydropic, you're in trouble.
Okay?
And plus, this an RH setup. All right, I'm sorry, go ahead.
So that was my thought process, was that, yes, they had the ABO to start, but the cause of the anemia now was the nadir, hitting nadir, and they were just set up to be lower because they had the ABO incompatibility at birth.
Yeah, I can see. Yeah, I can see that. Then how are you explaining the microspherocytes? Well, see, you can't just ignore it because you don't like it. See, because, I mean, if you have a physiologic baby anemia, they don't have microspherocytes. That doesn't, so that's telling you there's something else going on, hence the microspherocytes. So you have to read the whole, you can't just ignore parts that don't fit the answer that you want it to be. That will set you up for failure. Okay, I see what you're saying, and I'm not saying there's not a physiologic component to this. I might argue 8.5 is a little bit lower. I don't know. Dr. Pirich, what would you allow as a physiologic anemia? See, an 8.5 is a little bit too low for me. I might go to a 9, but I'm not sure I'd go to an 8.5, but I'll let you make that call.
Yeah, and I think, Liz, maybe what they wouldn't have maybe given you all the other stuff if they were trying to get you to get to physiologic anemia of infancy. I see where you're coming from too, but they wouldn't have given you all that. They wouldn't have given you that ABO setup and all of that if they wanted you. They would have said healthy term baby, and then now like a hemoglobin, like Stalwart said, probably a little bit higher than 8.5 if they wanted it to be physiologic.
Okay, 26, 4-year-old, high blood pressure. Hello, urinalysis with microscopic hematuria. This is a Wilms tumor, and I think most of y'all got that. 27, again, this is HS. You remember, lots of your hemoglobin issues can have an aplastic crisis. PNH can, hereditary schistososis can, sickle cell disease can. a lot of these things can have a hemolytic crisis, aplastic crisis. And so here is, they tell you her normally it's 10 with a retic count of 9 because she's got HS. But now it's 4 and she's not reticking, hence her bone marrow has been zapped. Her bilirubin is 1. Why is that in there? It's not hemolytic, it's a zap. And so you interpret this is aplastic. That's not the question. The question is the next layer. What would cause an aplastic crisis? And I think most of y'all got parvo B19. You know, it's your classic bug that does that. 26. Hello, this is goat's milk. You got it. You know that. Y'all know that. Anemia, goat's milk. Again, that's a pattern recognizer. That's going to be folate. Now, this question points out for me to teach you, if I can, when you say a child's mother insists that she's been giving the iron, don't play the game, well, mother's lying through her teeth. You see what I'm saying? That generally is not what they're setting you up. If it was a mother who was lying, they would probably have to say, the mother who's been in rehab and on methadone, and I mean, there's got to be something there. So don't try to say, well, I'm not sure she's telling the truth. I'm not sure she's giving it to her. Hence, you're going to answer it wrong. Buy into it. The adolescent female who says she's not sexually active. Now, that being said, depends on how the stem of the question goes. But don't go the other way. Don't say, oh, because she says she is not sexually active, that means she is sexually active. You see my point? There needs to be something else to say she's saying no, and that may be mother and child, or mother is a very religious person sitting in the room with her child. The child denies sexual activity. Well, now they're setting me up that that's not true. But if they don't frame it that way and the child denies, I would go with that in the stem of the question relative to the answers. Okay, 29, let's see. Okay, here's the raccoon eyes, the 2-year-old, you know, this is gonna be your neuroblastoma, and the eyes give it away. And again, notice the platelet count. Remember, with neuroblastoma, you have a high platelet count. So the platelet count is there for that reason. If you weren't sure, trying to tease out, well, could it be, you know, non-accidental trauma? And you do have to worry about that. And I got that. You know, you're kind of there. But then when you see that platelet count being up, it pushes you. And of course, she's got the left abdominal mass. Now, you could argue the left abdominal mass is a bleed because she's been sucker punched in the gut. I got it. But you're really trying to construct something to make that answer be what you want it to be, rather than reading the question and processing what's before you that can fit another answer. So answer here is going to be neuroblastoma. And number 30, this is a breastfeeding. This is kind of a classic born at home. And I think most of you got this as a vitamin K problem. Again, no petechiae, hence it's not a platelet. So E comes out, neonatal albumin thermoset comes out. It's a girl, C comes out. And you and I both know that if she'd have to be sick to be in DIC. I mean, she went to a lactation consultant. And so this is going to be classic vitamin K deficiency. And then the last question comes back to what I tried to teach you a while ago. Now here is no thumbs, not rudimentary, no thumbs. So you look at no thumbs and you're into those 3 categories I just told you. And since it's no thumbs, now again, you know, I could certainly agree with you that as you look at the picture, probably the radius is a problem too. I don't know. But remember it's a array problem. So you're coming down that radial line. This could be Holt-Oram. I'm not going to say it's not if I looked at the patient, but you don't have a 60,000 white count with Holt-Oram. So you got to play that in. So once you get the low platelet count and put together no thumbs, then this has to be diamond black fan. Now, that's not the question. The question is, now that I know what it is, what are we going to do about it? Or what's the best management? And so you just look at that. And of course, you want to make the correct diagnosis. You've got to get the diagnosis right. So the answer is going to be a genetics consultation. Dr. Pearce, you want to respond to this question at all?
I think it would be, now that the genetics consult, but I think it would be, this one would be TAR probably. With the
TAR?
platelet, yeah, with the platelet count of
Okay.
60,000, and the
What about the
abnormalities.
without thumbs? See, that without thumbs pushed me into
Yeah,
the diamond black fan.
yeah, and most of the time I would think that if they're going to give you diamond black fan, they're going to give you a really low hemoglobin.
Okay.
Not as much, I mean, you can have thrombocytopenia with diamond black fan, but the classic with diamond black fan is a pure red cell aplasia. So I would think that they would lead you down that pathway. That's what makes me think, since they gave you the platelet count, that they're
Okay.
leading you down the TAR pathway, maybe.
Okay. All right. So that's a good thing to look at. And then at least that would explain where that radius looks a little funky over there, especially on that
Yeah.
left arm short.
Uh-huh.
That would put you in that. So this is a little bit, could go either way, but I agree with Dr. Dr. Pearce knows better than I do. Don't misunderstand me. But the bottom line is that the genetics consultation is where you're going to go for that. Okay, so hopefully you've learned something. I think we're right on time, 1:16, so we will stop. Thanks, Dr. Pearce, for joining us. Thank Dr. Carney for keeping up. Dr. Carney, any other quick questions I need to respond to?
No, I was just asking if they would tell you that the patient was a figure skater if they had diamond black fan, but that's just for Dr. Pearce and Dr. Stallworth to argue about.
No,
No, that's going
that
to
would be
be
Schwachman Diamond.
that's going to be Schwachman Diamond, not
Sorry,
Diamond Black
sorry,
Fan.
sorry. My fault completely.
Named after Harry Schwachman in Boston. And it is, I think, the same Frank Diamond that does both of these, to be honest with you.
Yeah, yeah.
Okay. All right. Bye, y'all. Hope this helped.
Bye.